Hello,
Hello, Muhammad. How you doing?
Dr. Goel. How are you, sir?
All right. Can you get your camera working today?
Sorry,
Your camera's not on.
I just connected. What is the time will we start, sir?
About 20 minutes.
20 minutes later?
20 minutes.
Okay, sir. How are you?
Good. Your camera, put your camera on. The camera's not on.
Okay, I'll try the cam.
You just go to where the camera icon is at the bottom of the screen.
I'm searching for
Okay.
more. Mhm.
What do you have? An Apple? You have a laptop?
iPhone, yes.
Oh,
From
iPhone.
the yes.
iPhone is different. I'm not sure where you have that to turn on.
وعليكم
There,
السلام ورحمة
I'm
الله.
sure there's a way to turn the iPhone on.
I'm searching to open the cam right now.
Okay. Well, let me ask the internet. Okay, I got the answer. Mohammed,
Yes, sir.
I have it on the screen and to take a look at it.
Yes, I see the screen.
You see it? To turn on your iPhone camera during a Zoom, tap the start video icon, typically located in the bottom left corner. Do you see that?
CC cap. I cannot show my cam here.
Okay, just tap on it, just tap on the screen. It might bring
Um,
up the toolbar. There's a toolbar apparently you can't see. Just tap on the screen, it should appear.
I did, but nothing happened.
Okay, Mohammed, I'm your teacher. You gotta listen to me.
I'm listening to you, sir.
Okay, I'm gonna give you a message here. Hmm, Okay, I'm gonna send you a link. It's a short 1 minute video that tells you how to do it. Okay?
Okay, sir. You see now?
Hold on. For a minute. Okay, Mohammed, you want to try your camera now? Let me see if you got one. You don't have a camera connected, Mohammed.
It's already connected here.
It's not connect. I can see it's not connected.
Oh, let's try again. There's a meeting.
Okay, well, you don't have to have it on if you don't want to, or if you just figure it out later.
Touch up my appearance.
Mm. No, you don't have your camera connected.
Oh, I see myself now.
Hello, Dr. Kim?
Can you see me now?
Oh, hold on. Yeah, there you go. Hi, Dr. Kim.
Hi, Dr. Goel. How
How
are you?
you doing?
Can you see me?
Dr. Kim, I've never met you before. I'm Dr. Bennett.
You're Dr. Bennett. Okay. Hi, how are you?
You're from Korea. We used to do a lot of webcasting with Korea, most
Oh,
South Korea, mostly minimally invasive.
yes. We are very strong, the MIS
Yeah,
surgical
yeah,
teams in
yeah. There's
Korea.
a lot of webcasts there.
Yes. And especially these days, the UBE, unilateral bipolar endoscopic is a very hot issue in Korea.
Yeah, yeah. I'd like to reestablish ties with the webcast. Aquí está Roton Poquito.
Hello.
You remember Roton?
Hello.
You remember Roton?
Hi, Dr. Paris.
This is little
Hello, how are
Roton.
you?
This is
Good.
little
How are you?
Roton from Mexico.
From Mexico City.
Yeah, let me take this off here.
Hello,
How you doing,
hello,
Victor?
hello, John Bennett. Hello, everybody. I'm very glad to
Hello.
be here with you.
Dr. Kim, are you from Seoul? Seoul?
Yes, I am. Yes.
Okay. I've
Where
never
are you
seen.
from, Dr. Bennett? Where
From-
are you now?
I'm in
From-
Miami Beach.
Miami. That's the
Just
picture
say,
shows.
let me put my camera on. I don't even have it
Yeah.
on. I gotta put it on.
I can see you. Oh, yeah.
There we
Hi.
go. There we go.
I can see you.
Start that.
Hello, Professor Si-Hun Kim.
Yeah. You can call me Sean. Sean.
Sean.
Dr. Sean Kim. Yeah.
John, that's okay. Where are you now?
I'm in Seoul, Korea.
Oh, so good, very good. Very nice to see
Have
you.
you ever been in Korea?
No, never.
Not yet?
Not yet.
They're very big in minimally invasive
Yeah.
surgery. Very big. They televise a lot. Is it Dr. Kim? Is it Dr. Kim from Korea that does that? The very big person, a big neurosurgeon that
You
does a
mean the
lot.
Harrison Kim? Harrison Kim?
Maybe that's them, but
Yeah,
they were
endoscopic
doing a
guys.
lot. They were doing a lot of webcasts. Oh, there's
Young or Harrison Kim.
Abby Shah. Let's have a round of applause for Abby.
Hi, John.
Abby, we're trying to get you a round of applause.
Why?
Why not?
Okay. I'm in Chicago, John.
All right, Chicago.
And I met Jeff yesterday.
Oh, you met Jeff?
Yeah.
Oh, that's fantastic.
I was here for a conference, so I met him.
Oh, because he was in Boston.
Yeah, I went to Boston, yeah.
But yeah, okay, so he's not in Chicago now, right?
No, I'm back to Chicago, but I went to Boston.
Oh, you went to another conference in Chicago?
Same conference.
In Chicago? The Boston
In
conference?
In Boston.
Oh, you're in Boston now.
I was in Boston, now I'm in Chicago.
Oh man, you're hard to keep track of.
Don't worry.
We gotta put a GPS on you.
No need. John.
Very nice, Avi.
Hi, Dr. Victor. How are you?
We are very close, about 4 or 5 hours by plane.
Yeah, 4 or 5 hours. But I'm going back. I'm going back tomorrow. So
It's a long trip.
yeah.
How many hours from India
20.
to Chicago? 20.
Yeah.
Good. Not so long.
Yeah, not so long. It's okay.
Have you had the pizza in Chicago?
Yeah.
The big pizza, big thick pizza.
Yeah, yeah.
Have you ever seen that before?
No.
No,
Only
it's the only big pizza.
Yeah,
You gotta be hungry to eat one of those.
yeah.
Victor, you've had Chicago pizza, right?
Yeah.
Victor, have you had it? I don't know, Vic, he's been to Chicago, right?
Yes, yes,
You have the big pizza, they have big pizza there.
yes, of course.
Yeah.
Really, really nice food.
Yeah, it's famous. It's a meal.
Yes, yes.
The king is running late. So we have time.
Abida,
Yes,
you
Dr.
have you visited the museums in Chicago?
Yeah,
They are really amazing museums.
okay. I had been long time back, not recently. Yeah.
You should go to visit one of them. They are really, really amazing.
Okay. I'll go. John is here.
Oh, okay. There he is.
Hi, John.
Hello, welcome. Welcome, Arshad. Second one
Where
today.
is our king?
Arshad is being a good, the king is here.
Hi, John.
King is here. Acha.
I can see my dear friend Harshad. I think he can
Yes,
give a lecture. He can
king
give my
has come.
Harshad, you can give lectures better than me now. Dr. Kim is here. I can.
Great.
Hi, Dr. Goel. I just came from
Yeah.
Istanbul this afternoon.
Okay, okay.
Yeah.
Everything okay, Dr. Kim?
Yes, yes. Okay. You too?
Yes, yes.
Yeah, good to see you.
So let's enjoy this lecture now.
Hello, Professor Atul. Very nice to see you
Hi.
today.
Oh, Victor, you're looking great, Victor, as usual.
I'll start in just a second.
Okay, okay.
Okay, the title of syringomyelia and what else?
Chiari malformation.
Chiari and syringomyelia, right?
Right.
Okay, let's start here. We're ready to roll. The king is on a tight schedule. Okay, 10, 9, 8, let me see, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, the home of Neurosurgical TV. This is where we actually are at. We are honored to have the king of Zoom. And we say that because we admire him, because he does a lot of work and a lot of education. And today he's going to be talking about syringomyelia and Chiari syndrome. And we look forward to it. Welcome to the king.
Thank you, John. Thank you for all these nice words for me. No question that I'm enjoying giving these lectures on your platform. And there is no question that this platform has taken me to the corners of the world. And my message has been delivered loud and clear all over. So now this is another opportunity to enter into depth of Latin America through Victor. Victor, go ahead, Victor.
Hello, Professor Atul. We are very glad to see you. I think you are coming next August, I think, to Mexico City.
Yes, yes.
Yeah, we are very proud to having you here. It's really amazing what you show us about your spine surgery. So this is going to be a really amazing conference.
Thank you. Thank you. John, should I begin, you think? John,
I'm sorry. Yes, please.
should I begin?
Yes, please.
Okay. So welcome to all of you to this new world of Chiari malformation. I don't like to call it malformation. I like to call it Chiari formation. As you can see, Chiari formation. I have no hesitation to say, no hesitation at all to say that what I'm going to present before you is a complete revolution in this subject, completely different version from what has been going on for a few decades. I like to call it Chiari formation because I think it is Chiari or tonsillar herniation is useful or beneficial or essential or adaptation for in the presence of unstable atlantoaxial joint. So I wish to introduce this new concept, new treatment, and I also wish to introduce to you a new concept of central or axial atlantoaxial instability. I have no hesitation again to say that this concept of central or axial atlantoaxial instability is a complete revolution in the field of craniovertebral junction. It is, no matter how many times you have heard me before, no matter what you know about it, I wish to give you this message again, considering the huge relevance of this subject in the contemporary field of craniovertebral junction. So whatever sentences I speak, whatever I talk is based on very heavy publications. And some of these publications I have shown here, and it may be worthwhile. You see, nobody in neurosurgery or in spine surgery can say, I'm not interested in Chiari. If you're not interested in Chiari, you are interested in what? Chiari is indeed, you have to be interested in Chiari. How you treat Chiari, that is a different matter. You have to be interested. And if there is a new thought, a new kind of an idea, you cannot say, I will not read it. So I'm giving you several publications which can actually change the version of your thought process. And these are some more publications. I just now got the message that I have got 65 publications on PubMed on the subject of Chiari. And this is indeed a completely different version, different story of Chiari. One thing before I begin, I want to say that atlantoaxial joint, a thing which I have repeated n number of times, atlantoaxial joint is the most mobile joint. Atlantoaxial instability is the most common instability of the spine. It is the most neglected instability. And craniovertebral junction stabilization means atlantoaxial stabilization. That is important. You see what I'm saying is craniovertebral junction stabilization means atlantoaxial stabilization. This is one screw in C1, one screw in C2, open the joint, put bone graft in the joint. I used to do occipito-cervical fixation quite frequently, and I described these occipital screws for cranio-cervical fixation. Now I'm saying, is occipito-cervical fixation necessary? Is inclusion of the occipital, which the whole world is doing. Today, if you ask the world what they are doing for craniovertebral stabilization, 90% will say they are doing occipito-cervical fixation. I am saying inclusion of the occipital bone in a huge majority of craniovertebral junction surgery is not necessary. And it is suboptimal form of fixation. I'm not saying it is counter-effective. It is a method of stabilization. If you cannot do atlantoaxial, you do at least C1 occipital fixation. But that is not the optimum fixation. So it is not necessary. So this is my first sentence. So this is tonsillar herniation, we all know. And this concept that the posterior fossa is tight in tonsillar herniation, and that is why the tonsils herniate. This concept I had introduced in 1998. And now I'm saying this concept is not correct. What the current idea is, there is herniation of tonsil, there is compression at the region of craniocervical junction, and this compression leads to blockage of CSF pathways, and this leads to CSF formation. This is the existing concept. And I'm saying that concept is not correct. Now I will show you Chiari malformation can be associated with a number of pathologies. And I want you to see the posterior fossa, see the cerebellum, see the sulci and gyri, see the fourth ventricle. It is not tight. That is one thing I want you to carefully see in my slides. So this is tonsillar herniation and syringomyelia. This is, you see, this is not tight. I will not go on repeating you. Please pay attention to the posterior fossa. It is not tight. See the folia, see the CSF in the folia, see the fourth ventricle, see the CSF in the posterior fossa. And also I want you to see at the tonsil. Tonsil, if you see the folia here, you see there is large sulci here. But in the tonsillar herniation, this is a compact tonsil. You will not see sulci here or folia here. Then in this patient, there is small little syrinx and there is a large fluid collection in front of the cord, which I like to call external syringomyelia. There is a large volume of CSF in front of the brainstem, which I like to call external syringobulbia. So you keep track of these words which I am giving you. Now this patient has internal syringobulbia, syringomyelia, external syringobulbia, and see the posterior fossa is not tight. Syringomyelia and Chiari malformation very frequently are associated with basilar invagination. Now the question is basilar invagination a different entity? Or is the treatment of Chiari in presence of basilar invagination different? So these are the questions. This is another case of huge basilar invagination, platybasia. You see the posterior fossa, you see the folia, you see the tonsillar herniation, no folia here. You see the syringomyelia, see the large spinal canal and Chiari malformation. This is another case of Chiari, syrinx, small syrinx, large subarachnoid spaces, which I like to call external syringomyelia. You see the subaxial spinal alterations, reduction in the disc space, changes in the body, alterations in the alignment, and things like that. There is no compression here. The problem is craniovertebral junction. Sometimes you can see manifest atlantoaxial instability. Atlantodental interval is increased in the presence of Chiari, in the presence of external syrinx. You see external syringobulbia, fourth ventricle is normal, posterior fossa is not tight. But there is manifest atlantoaxial instability. This is another case of manifest atlantoaxial instability, tonsillar herniation, external syringobulbia, no syrinx. So this permutation and combination, basilar invagination, syringomyelia, manifest atlantoaxial instability, are common kind of phenomena. This is another case of manifest atlantoaxial instability, which the whole world was calling as fixed dislocation, and a decompression kind of treatment was going on for decades. And this is syringomyelia, large syrinx and small syrinx. Here in this case, there is no craniovertebral junction, basilar invagination, no bony abnormality, no platybasia, but there is Chiari and there is syrinx. So there can be associated bony abnormality or not associated bony abnormality. This is another case, there is no real bone abnormality here. There is syringomyelia, there is external syrinx, there is external syringobulbia, there is tonsillar herniation, but the posterior fossa is not tight. As you will realize, the whole world will like to do foramen magnum decompression in such cases. This is the treatment. We described in 1998 that there is no need to remove the bone. Some people remove the bone, some people do not remove the bone, some people open the dura, some people patch, and all kinds of treatment. So this is the conventional treatment for all kinds of Chiari. Decompression of various kinds, tonsillar resection, plugging of the obex. There are n number of treatment. And in one of my articles, I said the number of surgeons treating Chiari, the number of treatment is equal to number of surgeons treating. Everybody has a little bit difference here and there, and they think that their treatment is the best. Some people remove the occipital bone, some people remove C1, some people remove C2. So decompression is the norm, is the treatment. So I wish to introduce to you another form of treatment. That compression is never never a problem in spine. And decompression, which the whole world is doing, is never the treatment. So this in relation to Chiari, I will discuss today. Just to introduce the subject again, which I had talked last time, just to little bit go further, this I had devised in 1998, basilar invagination into two groups. One odontoid goes up and one Chiari, one tonsil coming down or Chiari malformation. And I had divided into two groups. For group 1, I had said transoral decompression. For group 2, I had said foramen magnum bone decompression. In this article, if you read carefully, I had said that the posterior fossa is tight. So this tight concept was introduced in this article. In 2004, this I am repeating again just to come to the subject. I said that in 2004, group A, odontoid goes up and it can be brought down by distraction of the facets, and we can achieve craniovertebral junction realignment. For group B, I had said that these patients need foramen magnum decompression. So you see how my journey of Chiari in 2004, I had myself said that foramen magnum decompression, bone decompression, even in the presence of syringomyelia should be done. And for this group, and many of you know about my treatment, and this treatment in 1998, we said that brainstem is compression, so the transoral, and in group 2, foramen magnum decompression. We had said that bone decompression should be done for cases of Chiari malformation, and there is no need to do dural decompression. And over the years, group 1, distraction of the facet, distraction and realignment, distraction and realignment, distraction and realignment for group 1. And this we had discussed in our last lecture about distraction, reduction, and fixation. And I have no hesitation to say, absolutely no hesitation to say, that my articles in this field have completely put transoral decompression into the history books. And many of you interested in craniovertebral junction know that this is completely a historical version. As regards craniovertebral junction, we had stressed on the importance of facets, and even for subaxial spine, we have said that there is a facetal instability due to muscle weakness, muscle injury, muscle strain of the nape of neck due to human standing position on two legs. We can have weakness and there can be vertical facetal instability. In 1998, for the first time in the literature, we said that basilar invagination is nothing but C1 over C2 listicin, like lumbosacral listicin. And we had said that like you treat listicin, you treat basilar invagination. So these slides, which I had shown in my earlier lecture, basilar invagination, listicin is the problem, reduction, stabilization, realignment is the treatment. No role of decompression. So at that time, in 1998, I had presented several cases like this. When there is manifest atlantoaxial instability in presence of Chiari and syringe, in 1998, we said, this is the problem, this is the treatment, no need for decompression. I have to tell you now that a whole lot of world today will either do transoral decompression or foramen magnum decompression for this entity. This is another case of Chiari and syringe. You can imagine what people will do for this. And this is the treatment, realignment, and stabilization and fixation. So over the years, what we have done is we have understood that there are two types of craniovertebral and subaxial instability. One is acute instability and one is chronic instability. And we have talked about stability and motion in various articles, and we have talked about central and axial instability. This concept, as I was mentioning, that central or axial craniovertebral junction instability is the genesis, is a chronic instability. This is chronic, and this is the forms the genesis of Chiari, syringomyelia, and several other problems. Today, I am going to focus on Chiari and syringomyelia. I am not going to talk about OPLL, deformation, spinal fixation, bifid, and all those things. Also, odontodium, I'm not going to talk. I'm going to talk of central instability and Chiari and syringomyelia. As I have talked about this, and this slide is my favorite slide, you see this is the listhesis, C1 over C2 listhesis. There is instability. You see there is no tight posterior fossa. Reduction, fixation is the treatment. This is now understood. Most of the world is now doing this. The world which is not doing what is in this case. You see, there is severe basilar invagination, Chiari, and syringe. There is no problem here, but there is retrolisthesis, C1 retrolisthesis. For this basilar invagination, the whole world is today doing foramen magnum decompression. What I have said is this is unstable and this needs stabilization. Another thing is this, the third case, there is no atlantodental interval disturbance, no facetal malalignment, but Chiari and syringe, everyone likes to do foramen magnum decompression, and many or majority likes to do syringostomy or subarachnoid shunt and things like that. What we have said is that presence of Chiari, presence of syringe, presence of assimilation, presence of platybasia, presence of Chiari, presence of syringe are all secondary chronic manifestations of atlantoaxial instability. Atlantoaxial stabilization is the treatment, and magic will be the clinical result. Syringomyelia will reduce. Whether it reduces or not is not the issue, but the patient will dramatically recover. So what I do is, when there is no atlantodental interval disturbance in type 2 and type 3, I like to call these two clinical entities as central or axial atlantoaxial instability. This is a chronic instability, and I will like to show you several cases. So chronic instability, carefully see this slide. This slide is a complete revolution. Believe me, I am saying on the basis of my experience that this slide is a revolution. What I'm saying is chronic instability is the father of Chiari, father of basilar invagination, father of C2-3 fusion, father of bifid, odontodium, assimilation of atlas. Here there are only few mentioned, but I was calculating more than 70 issues which are currently considered pathological have their genesis in atlantoaxial instability. Chiari may be present. Now, other thing which I mentioned is Chiari is sometimes associated with basilar invagination. So this father has two children. Sometimes Chiari is associated with syringomyelia. So two children. Sometimes this father has three children, Chiari and basilar invagination and syringomyelia. Sometimes it has four children, C2-3 fusion, assimilation of atlas. So all these entities which are here are manifestations of chronic instability. They are all protected, they are all adaptive, and they are all potentially or manifestly reversible after atlantoaxial stabilization. No question, understanding this slide will change your life in craniovertebral junction. And we have written several articles on this subject, and this was my article which I had written a few years ago, and various other articles which you will like to see. So what happens is, in chronic instability, the nature or God or the upper zone comes in the picture and protects. So nature's reparative gain. So all these things like Chiari, syrinx, assimilation of atlas, short neck, bifid, torticollis, all these things are secondary nature's reparative or protective gains. The father is atlantoaxial instability. So these are all children, and they will continue to play if the father is all right. So for all these and many more, I have not written several here, like assimilation of atlas, bifid, short neck, short head, torticollis, clipal file abnormalities are not mentioned here too many, but there are also about 70 problems which the world today considers pathological have their genesis in atlantoaxial instability. The whole world treats all these anomalies by decompression. I am saying all these anomalies need one treatment, and that treatment is atlantoaxial stabilization. So look at the facets, and they may be unstable even when there is no other evidence of instability, and you have to do stabilization. So this kind of basilar invagination, whether you see unstable facets or not, this is unstable, even if they are in alignment. This needs C1, C2 fixation. This does not need any kind of decompression. Now, give me your honest opinion. Do you think there is anyone in the world today who will not do decompression in this case? Do you tell me that? Frankly, you tell me. Is there any person in the world who will not do decompression? I am saying decompression is a negative form of treatment. Stabilization is the treatment, and instability is the question. This is another case of sorry for that. This is another case of complex basilar invagination. Look at the Chiari. There is not much problem here, not much problem here. Tell me the truth. What do you think? The whole world today will do this by foramen magnum decompression. I am saying clearly, definitely, you are losing a chance to give a new life to this person. This is clearly an unstable phenomenon. Stabilization is the treatment. So this is another case of Chiari with syringomyelia. There is some instability. There is significant facetal malalignment. Stabilization is the treatment. This, of course, there's no need for any kind of decompression. So I will show you several cases, and be ready and prepared to see. There is Chiari and syrinx. No problem here. No problem here. And I have done C1, C2 fixation without any kind of decompression. So basilar invagination, syringomyelia, Chiari malformation, all these things are children of atlantoaxial instability. Instability is the cause, and stabilization is the treatment for both type 1, type 2 basilar invagination. Instability is the issue, stabilization is the treatment, and we have published several hundred cases now we have got on in both these clinical entities. So there is no role for any kind of decompression, which the whole world was doing. And in group 2, the whole world is still doing. And in this group, many of people have now changed. So basilar invagination, syringomyelia, Chiari malformation, are secondary to atlantoaxial instability. I wrote this article on the basis of 65 cases. Is atlantoaxial instability the cause of Chiari malformation? Is atlantoaxial fixation the treatment? This is what I had written. And there was, as soon as I wrote, there were many letters to editor and things like that, and many complex questions were asked to me. And this is the treatment which was followed earlier. And I wrote this article, Is atlantoaxial instability the cause of Chiari? And you see these letters to editor in Journal of Neurosurgery, many letters to editor. I don't think there is any article in the literature on which there were so many letters to editor that were written at one time. So I am happy that this article of mine invited so much of interest in the academics of the world interested in Chiari. More recently, about 5 years ago, I wrote this article on Chiari and my experience with 388 cases, all treated by C1, C2 fixation. Magic, all cases, magic clinical result. And you have to read this article. Now my experience is beyond 600, and there is no question and there is no argument as far as I am concerned. So I will show you some pictures of Chiari and syrinx. This is syringomyelia, this is Chiari. There is not much problem here, little bit problem here. As I've said, whether there is little bit or nothing or more, this is unstable. This is manifestation of unstable spine. You do stabilization, the syrinx will reduce, and in about 4 months, 100% cases syrinx will reduce. In 10 days, at least 20% of patients, the syringomyelia will reduce. So be prepared to now see many cases. This is Chiari. There is no problem here. There is no problem here. No decompression, only C1, C2 fixation. This is basilar invagination, assimilation of atlas, no atlantodental interval disturbance. Quite a significant Chiari, syringomyelia. You see not a tight posterior fossa, external syringomyelia, external syringopulpia, fourth ventricle is not affected. Foramen magnum decompression, in my view, is a complete negative treatment in presence of a completely lax posterior fossa, in presence of a completely unstable atlantoaxial joint. You do C1, C2 stabilization. This is another case, no problem here, syringomyelia, Chiari malformation, no problem here, no problem here. I have done C1, C2 fixation. This is another case, no problem here, no problem here, no problem here. See the syringomyelia, see the tonsillar herniation, no tight posterior fossa, no problem with the fourth ventricle. I do C1, C2 fixation. This is syringomyelia. Again, I am repeating. It is not the syringomyelia reduction which is the glory or which is the trophy. I am saying the patient will recover dramatically and drastically in the evening of operation, and the person will get a new life. So this is another case after 3 months. This is Chiari and this is reduction of syringomyelia. This is also another case. You see syringomyelia. And another thing, this is unstable C1, C2. Here the reduction is not complete, but completeness of reduction is not the issue. Reduction is the issue. Stabilization is the issue. Stabilization is the issue, not reduction. So this is another case of syringomyelia. Not much problem here, not much problem here. Reduction in the syrinx, increase in the external syringomyelia, reduction in the tonsillar herniation, C1, C2 fixation. This is another case of complex Chiari where there is severe basilar invagination, syringomyelia. These cases are not easy to do. Many people will like to do occipitocervical fixation in the presence of assimilation of atlas. Maybe I will say they are not wrong, but the solid fixation that you can get in direct C1 fixation, C1, C2 fixation, you cannot get otherwise. More important, as I have mentioned, That opening of the joint is critical. Putting bone graft is critical. Here I could do only one side, and you see the bone fusion. Chiari is secondary, Chiari is protective, syringomyelia is secondary, syringomyelia is protective, short neck is secondary, short neck is protective, torticollis is protective, bone fusion is protective, assimilation of atlas is protective, and all these things. Assimilation of atlas, basilar invagination, Chiari and syrinx, only fixation. This is Chiari. You see no tight posterior fossa, basilar invagination, no malalignment, only C1, C2 fixation. You see this preoperative image, Chiari and syringomyelia. This is after 10 days of surgery. You see the syringomyelia reduced. And this is after 6 months of surgery, syringomyelia reduced. So syringomyelia will reduce after C1, C2 fixation in 100% of cases. I am saying C1, C2 fixation will reduce syringomyelia, all right, but it will give a brand new life in the immediate post-operative period. So this is preoperative image, syringomyelia, Chiari malformation. You see assimilation of atlas, little bit unstable, C1, C2 fixation, reduction of the syrinx. This is another case of syringomyelia, basilar invagination, no problem here, little bit assimilation of atlas, no problem here, C1, C2 fixation, no change. You see, there is no change here. There was no compression before, there is no compression now. So compression is not the issue. Don't just work on compression. Instability is the issue. And magic is the clinical outcome. This is another case of basilar invagination, assimilation of atlas. There is severe Chiari and syringomyelia, only C1, C2 fixation, reduction of the syrinx. This is another case, reduction of the syrinx. This is another case of, sorry for that. This is a case of complex syringomyelia, basilar invagination, assimilation of atlas. There is assimilation of atlas, only fixation. There was no compression earlier also. There is no compression now, only stabilization. Syrinx has reduced. This is another case of complex basilar invagination with fusion and Chiari and syrinx. You see the syrinx has reduced, only C1, C2 fixation for complex surgery. But complex surgery is our life. Chiari is a complex subject. Chiari is a disabling subject. Chiari disables. Chiari troubles, then disables, then cripples, and then kills. So for this killing disease, we have to do a complex surgery, and that is what is necessary. So this is basilar invagination, Chiari, syringomyelia. I do only fixation, syringomyelia reduces. Chiari, see the unstable, I do only fixation, tonsil goes up. So you please see the issue which the whole world will do, foramen magnum decompression. So what I am giving you is a different version of craniovertebral junction. Chiari malformation, you see the syringomyelia, you see there is no tight posterior fossa, you see unstable spine, you see unstable spine. I do only fixation, syringomyelia finishes after some time. This is another case of syringomyelia. This is similar looking case like what I showed earlier, syringomyelia reduced in size. This is another case, similar looking. Most of these cases have assimilation of atlas. This is another case of Chiari and syringomyelia. Syringomyelia reduces after fixation. Another case of Chiari and syringomyelia. This is tonsillar herniation. You see how the tonsil have gone up, and this is only fixation. This is another case of basilar invagination. There is assimilation of atlas, only fixation. Imagine, you just imagine, I want to ask you a question. What will the current neurosurgery do for this case? the whole world of neurosurgery or spine surgery, what will you do for this case? You will do foramen magnum decompression. No other treatment has been recommended for this. And you see, I have done C1, C2, no foramen magnum decompression, syringomyelia reduced. This is another case of very severe basilar invagination, extensive syrinx, not much problem here. You give me your answer. What will you do for this? You will do, the whole world will do foramen magnum decompression. You see how the syringomyelia has reduced following C1, C2 fixation. This is a case of 48-year-old female, pain in the neck and tingling in the hands. This is the syringomyelia. This is the case, inflection and extension. Facets are in alignment. This is post-operative. This is the operation done. You see the syringomyelia reduced. The patient gets a new life. And when I wrote this article, many people said that this might not work in cases where there is no bone abnormality like basilar invagination, assimilation of atlas, and things like that. So I wrote one article 5 or 6 years ago, atlantoaxial fixation for Chiari, where there is no bone abnormality, like there is no basilar invagination, no assimilation of atlas, no bone abnormality in this Chiari and syring. And as I have said, so let me show you these kind of cases. You see, there is no basilar invagination here. There is no assimilation of atlas here. This is Chiari, this is syringomyelia. A little bit unstable here, which nobody recognizes. The treatment, standard treatment is decompression for this. You see what I am doing is C1, C2 fixation. The syringomyelia has reduced. This is another case. There is no basilar invagination, no assimilation, no C2-3 fusion, nothing of that kind. And you see, this is the reduction in the syrinx, and this is the treatment. This is another case. There is no problem in the craniovertebral bone, no basilar invagination, Chiari, syringomyelia. See, little bit unstable. I do fixation, and you see reduction in the syringomyelia. This is another case. There is little bit syrinx. This is postoperative syrinx has reduced. And you have to believe in me that these patients get new life. They improve in the symptoms in the hands. The tingling is reduced. The power in the hands is improved. The spasticity in the legs is improved. The voice is improved. The breathing is improved. And you ask them new life after surgery. This is another case. There is no bony abnormality in the craniovertebral junction, no basilar invagination, no assimilation, no C2-3 fusion, no clipal fright. There is facetal malalignment. Do fixation. Magic is the clinical outcome and the radiological outcome. See the syringomyelia, no problem here, no problem here. I've done C1, C2 fixation. The syrinx has gone. Syrinx will not actually go, but it will reduce. You see, this cord formation will not, new cord will not form, but it will reduce inside. Like this syringomyelia will reduce inside. There is no treatment. This patient, now you see I have no words to say that this treatment, if you do and foramen magnum decompression, as I have told you, I was doing foramen magnum decompression. I described only bone decompression. I described foramen magnotomy as a treatment. But today I am saying C1, C2 stabilization is a magic treatment, and magic is the radiological outcome that you are seeing. You see this reduction in the syrinx. This is no problem here. C1, C2 fixation. This is syringomyelia. No problem here. No problem here. I do C1, C2 fixation. This is syringomyelia preoperative. No problem here. Little bit problem here. This is postoperative. This is syringomyelia. This is postoperative. This is facetal malalignment. I do only fixation. This is syringomyelia. No problem here. No problem here. I do C1. What I'm doing, showing you are only relatively straightforward cases. I'm not showing you very complex kind of cases. You see this syringomyelia, a little bit basilar invagination is almost always there. We had also said in syringomyelia there is short head. vertically short, transversely big, short spine, vertically short and transversely big. No problem here. No, I do fixation. You see the syringomyelia has reduced. This is another case, no problem, reduction. This is another case, preoperative, postoperative, only fixation. This is another case, syringomyelia, Chiari malformation, no problem here in the craniovertebral junction. I do C1, C2 fixation, syringomyelia reduces. This is another case, syringomyelia, tonsillar herniation, not much problem here, little bit problem here. 3 months after surgery, syringomyelia reduced. And I'm repeatedly saying the patient gets a new life. 35-year-old neck pain, spastic quadriparesis. You know how these patients present. You know how miserable these patients are or will become eventually. Syringomyelia, you see here, no decompression, only fixation, syringomyelia reduced. This is another patient, syringomyelia reduced after 6 months of surgery. This I have shown you earlier. Now what is the other thing is, now you will be surprised that I am getting cases of failed foramen magnum decompression. This is my most frequently done operation today. Now this patient has syringomyelia, Chiari malformation, foramen magnum decompression has been done, failed. This patient was a radio singer and she forgot to sing. Her voice became hoarse. And I did C1, C2 fixation. She's back in radio singing. And this is postoperative reduction in syring. This patient underwent 13 operations before he came to me. And then I did C1, C2 fixation. He went foramen magnum decompression. Then he underwent C1, C2 decompression. Then he went various kinds of shunts. Then he went lumboperitoneal shunt, 13 operations. And then I did this and a new life. This is another case. There is shunt here, there is decompression here, and several times this young man was operated and in a miserable condition. And he came with a Ryle's tube. And you see, this is when I discharged him, he was already without a Ryle's tube. And I have to give you one information. Till date, I have operated on at least 10 cases where post-operatively I removed the tracheostomy. Patients were on tracheostomy. I have removed Ryle's tube in at least 25 patients. Patients were on Ryle's tube following decompression and all those things. And I have removed Ryle's tube in at least 25 patients. This is another case of failed foramen magnum decompression. There is, you see, decompression has been done. And then I did, not decompression. This patient had undergone this kind of fixation. But this fixation, patient had not improved. So I removed this implant and I did C1, C2 fixation and a dramatic clinical recovery. So if the patient if you have not done a solid fixation, you might have a situation where your patient has not improved. This is another case, miserable patient, several times operated decompressions and things like that. Then I did fixation and a magic. See what I'm saying repeatedly, magic, this, that, because I'm so happy and dramatic revolution we have created in this field. No question, no doubt, no argument, no discussion as far as I am concerned. I know you will have several questions and you must have because you have been doing decompressions. This is another case of syringomyelia and foramen magnum decompression was done somewhere, then I do fixation. As I have told you now, my most common operation on this subject which I am doing is failed foramen. This is another failed foramen magnum decompression. And then I did this C1, C2 syringomyelia reduction. Another question that was asked to me is when I wrote this article that it will work in adults, but it will not work in pediatric age group. I have to tell you in pediatric age group, the atlantoaxial joint is more unstable. Many of these patients come with sleep apneas. Many of these patients come with incontinence of urine, nocturnal diuresis. Many of these patients come with speech problem. This problem is much more severe in pediatric age group and the results are much more dramatic in pediatric age group. You see this patient in a young child, quite a complex syringe, Chiari, not much problem, not much problem. You see, if you do C1, C2 fixation, new life to this child. This patient who came having difficulty in walking started running, and you see the smile on the mother's face and the smile on the child's face. This is another child, basilar invagination, relatively unusual in children. So this is basilar invagination, syringomyelia, and this is not a problem. Any kind, and you see no tight posterior fossa. I do C1, C2 fixation, the syringe has resolved, the patient has dramatically recovered. This is in presence. So this basilar invagination, assimilation of atlas, clipal file abnormality, C2-3 fusion are same brand. They're all secondary. If a person comes with only C2-3 fusion, this chapter, of course, I will discuss in my next lecture, that if the patient comes with only assimilation of atlas, what you will do? You will do C1, C2 without any problem. If the patient comes with only C2-3 fusion, what you will do? Only C1, C2 fixation. This is another case of syringomyelia in a child where I did fixation, and dramatic is the clinical outcome. This is another case of in a child where I did, you see this, no problem here, no problem here, no problem here. And I do C1, C2 fixation and instant recovery in all the major symptoms like voice changes, breathing changes, sleeping pattern changes. This patient has never slept supine in the last several years. Post-operatively, most of these patients will not only sleep supine, they will sleep in any position, and they will sleep comfortably like they have never slept before for several years. So these are magic kind of situation. This is syringomyelia, no problem here, no problem here, no problem here. C1, C2, you see, this is completely unstable rotatory dislocation, a chapter which I will discuss at the end of my story, that there can be rotatory atlantoaxial instability in these cases. So this is the case, complex craniovertebral junction, multiple fusion, C2-3 fusion, assimilation of atlas, syringomyelia, Chiari malformation. Look at the posterior fossa, it is not tight. Now I ask you a question, what will you do for this? What will the whole world do for this? And my answer, I will not be surprised if all of you say that I will do foramen magnum decompression. And I have to tell you, a new system, a new treatment pattern has come. Difficult treatment, complex treatment, dangerous treatment, but the treatment, that treatment is C1, C2 fixation, and this is the result, radiological result. This is another complex Chiari, which I think I have shown earlier. You see this smile, this misery, this smile in the immediate post-operative period. I think you have the potential, you have the power to give new smile, new life to these patients. New radiological picture is all right. Like I say, Chiari is helpful. That is why I say Chiari formation. I don't like to say Chiari malformation. Similarly, syringomyelia is another child of atlantoaxial instability. Syringomyelia is a product of atlantoaxial instability. It is helpful and not harmful. In 1996, I wrote this article that is syringomyelia a natural protective phenomena. I have no hesitation to say. And I have to also let you know, the whole world was treating syringomyelia by syringopleural, syringosubarachnoid, all kinds of shunts, the whole world was treating. Now you answer my question. How many people are doing syringosubarachnoid shunts? There are still many doing, but not all. And I have to tell you that these articles have certainly influenced the treatment pattern in these patients. When Chiari is present alone, it is atlantoaxial. When Chiari is present with basilar invagination, atlantoaxial instability is the problem. If syringomyelia is present alone, without basilar invagination, without Chiari malformation, atlantoaxial instability, what the world calls idiopathic syrinx, is not idiopathic. Like this, there is no Chiari here, no problem here, syringomyelia. What will you answer this question? I have got several patients in my series of this kind with the traditional term to use is idiopathic. This is, you can give instantly a new life and you can create an instant disaster if you do any kind of shunt in this patient. This syringomyelia with external syrinx, internal syrinx. And no problem here. No problem here. These patients need C1, C2 fixation. Another entity which I have been talking about several times is external syringomyelia. You see the fluid outside the cord. External syringobulbia. CSF, more syrinx outside, more fluid outside the brainstem. You see there is no tight posterior fossa. There is no folia over the tonsil. This syringomyelia, external syringomyelia, has equal significance to internal syringomyelia. And I have to tell you one thing, and this is from my absolute understanding, I am saying that this understanding of external syringomyelia has the potential to completely revolutionize the subject of craniovertebral junctions. Now you see this patient has external syringomyelia, external syringobulbia. This one has syringomyelia and external syringomyelia. And this has syringobulbia and external syringobulbia. All these issues are focused on atlantoaxial instability. See this Chiari? Internal syringomyelia. Chiari, syringomyelia. External, internal. Now this article I had written with my daughter. External syringomyelia in long-standing benign foramen magnum tumors. You see this tumor? Why there is more fluid outside the cord, outside the spinal cord, outside the brainstem. These are all secondary. These are all protective. These are all adaptive. You remove this and this will have the potential to recover. Now this is syringomyelia, huge syringomyelia. No problem here, little bit problem here is there is associated kyphoscoliosis. Short neck, torticollis are manifestations, protective manifestations of atlantoaxial instability. I will discuss about short neck torticollis in my subsequent chapter, in my discussion. But today what I am saying is short neck torticollis are associated with atlantoaxial instability. Kyphoscoliosis, dorsal kyphoscoliosis is also frequently associated with syringomyelia. This kind of, so there is no need to treat this. You treat and this will recover. Not completely, but significantly. I have written in this article, spinal kyphoscoliosis associated with Chiari and syringomyelia, recovery following atlantoaxial stabilization. So this is Chiari and syrinx, and this is kyphoscoliosis. Do not treat kyphoscoliosis. You treat atlantoaxial instability. So this is immediate post-operative, in about 3 or 4 months after surgery. Not only external appearance, this patient had breathing problem, which was related to kyphoscoliosis. This patient had spastic quadriparesis, which was related to kyphoscoliosis. And if you had treated this, you would have created disaster. This patient has got a new life. This patient was treated with multiple screws. You see these screws are rods are pouting from the spine. And this was pre-op, and this, of course, different patient. This is pre-op and post-op. And I have got several patients in my series where this kind of hump has gone after surgery. This hump does not let the person sleep supine. About 70% of patients with Chiari will have a hump here. So this is the patient I have shown, and this kind of kyphoscoliosis is a very frequent. And also another thing is, Like I said, sometimes there can be syrinx without any other problem. I said basilar invagination can be without any problem. Sometimes there can be short neck without any problem. Sometimes there can be torticollis without any problem. But the problem lies in craniovertebral junction. Similarly, there can be scoliosis without any other problem, and there can be syringom. And like in this patient, there is a severe, and there is not much problem here. You see, there is not much problem here, but there is a central instability. I treat this with C1, C2, and magic is the clinical result, not only in kyphoscoliosis, but in all other forms. So this is the patient. This was the huge, you see, there was no craniovertebral. You see here, there was nothing here. So there can be kyphoscoliosis with central atlantoaxial instability. So rotatory dislocation can present craniovertebral. You should look at the craniovertebral junction in this age group in particular. So is central atlantoaxial instability, can it be sometimes there can be idiopathic kyphoscoliosis. Instability can be the problem. Craniovertebral junction instability can be the cause of sixth nerve weakness. You see, this patient cannot move her eyes. Here there is sixth nerve weakness. And this is now she's moving in the immediate postoperative. So this Chiari basilar invagination can present as sixth nerve and various kinds of eye movement disturbance. This is another patient. You see here, they cannot move on this side. Now this is after a few months of surgery. This is pre-op. This is basilar invagination, Chiari and syrinx. And this is the issue. Voice quality affection. You see, many of these patients come with voice. This was my article in World Neurosurgery. Let me show you. You see this voice? This kind of. This kind. This was the voice before operation.
Shout. Shout.
You see this voice? You see the voice change. Voice is a manifestation of breathing. Voice is a manifestation of breathing. And you see, if the breathing is not good, the voice changes. So my article says that voice is not due to lower cranial nerve affection. It is due to difficulty in breathing. And about 60% of patients with Chiari will have voice disturbance. And this voice disturbance will recover in the evening of operation like a magic. And when voice recovers, it means the breathing recovers. And if the breathing recovers, the person has got a new life. Another new thing that we are working on is the rotatory dislocation, this central instability. We have identified the role of dynamic imaging. See here now, there is syringomyelia, there is no problem here, no problem here. But you do rotatory imaging. You see the facetal malalignment? Very severe facetal malalignment. I'm working on this subject that these patients have unstable C1, C2 on rotatory imaging. This is another case of Chiari, no problem here. And you see significant facetal malalignment on rotatory imaging. This subject I will come and discuss with you after a few months because I'm still working on it. I had recently discussed the role of dynamic imaging in traumatic instability. And this is also a very fantastic. Another beautiful article I wrote on motor evoked potential. You do C1, C2 fixation and recovery in the motor evoked potentials during operation. Now, this patient I had operated, and during operation, there are 40% improvement in the motor evoked potential. Majority of my patients will improve at least 30 to 40% at the time during the operation. So in short, craniovertebral junction surgery is difficult. Craniovertebral junction surgery is dangerous, but craniovertebral junction surgery can give new life, new smile, new kind of happiness, and you can make them kings. And you can personally get kisses after kisses from the patient, from the relative, and you have done a big thing for the lives of these people. So thank you very much, my dear friends. I hope you have enjoyed. I hope, John, I have not gone too far beyond time. And I hope and I wish that I can have many questions from all of you. Thank you very much. Victor?
Okay, Victor.
Hello, Professor Atul Goel. There is a question from Marcos Porto from Brazil. He said that Dr. Goel, having
Hey, Victor, he's here. Marco's here. Marco's
I'm
here.
here.
okay,
I
okay.
can make the question direct to the king.
Yeah, go ahead, Victor.
Thank
Go
you,
ahead.
thank you. Go ahead,
Okay.
please.
Dr. Goel, can you hear me?
Yes, yes.
Okay.
Marcos, go ahead.
All right. Having developed fundamental techniques such as C1, C2 fixation and atlantoaxial joint distraction, what do you consider the next frontier of biggest challenges to overcome in craniovertebral junction surgery to further improve outcomes for patients with this instability? Hello from Brazil. Good morning.
Thank you, Marcos. You see, to do a good C1, C2 fixation, do good, open the joint, introduce bone graft, as you have heard me, Marcos, several times, and you have come here to India to see this technique, and I have shown you in front of your eyes, and I have shown you how beautiful this technique can be, how solid this technique can be, and how result you give new life. So developing this frontier to go and more operations you do, more and more. You see, for all these problems, where we are doing, the whole world is doing foramen magnum decompression, it is absolutely necessary to develop this idea, this thought process, that this is the treatment, decompression is not the treatment, for several anomalies, which I have mentioned, and which I will discuss further in my next lecture with you, Marcos, that this is absolute, and this is an absolute revolution in the field. Marcos.
Thank you, Professor.
Shailendra is there. Shailendra, you are there? Magdum?
Yes, I'm here. Yeah, thanks.
Yes, Shailendra, go ahead if you have any questions. I know Shailendra is one senior neurosurgeon from England. He is, of course, very much Indian, will remain Indian no matter what he says and what he considers. But I'm looking forward to your question, Shailendra.
I don't have questions. I have a few comments to make. Basically, to say that the Chiari malformation is just one entity, which atlantoaxial instability is part of it and is the only part of it, is a bit too far-fetched unless we have got every patient who has a Chiari gets an X-ray and a CT and a flexion extension. We used to say there is instability and then you can fix it. That will not stand in the country which I practice, because you're exposing someone to radiation, and that is not, you get motion in children. There's more motion in children, as you say. But from where I come, I treat children who have got raised ICP, who have got syndromes, who have got Chiari. For them, they have got hydrocephalus and Chiari. So if you treat hydrocephalus, the Chiari disappears. If you treat hydrocephalus properly, the syringe disappears. I have patients who have got idiopathic intracranial hypertension who have got Chiari. So I label Chiari, in my definition, Chiari is primary or secondary. I have got scans from kids who are born day one with no Chiari and develop Chiari by 1 year, who also have the other way around, have got Chiari because of mismatch. As the head grows, the Chiari gets better. So just to say that Chiari is something which is just related to instability is, you have to consider a lot of factors.
Tell you the truth, Shailendra, you just did not understand what I was speaking. Unfortunately, I was not talking of secondary Chiari. I'm not talking of tumors and Chiari. I'm not talking of hydrocephalus and Chiari. I'm not talking of craniostenosis and Chiari. This is those are different entities completely.
Yeah, that's what I wanted to say that people should understand that Chiari is not just
what I am saying is, I am saying for the cases where you like to do foramen magnum decompression, that conventional, the whole world is doing foramen magnum decompression. For those cases I'm talking. I'm not talking of cases where there is a tumor and syringe. How will you do syringe or treat syringe by in presence of tumor? Or how will you treat Chiari in presence of craniostenosis? How will you treat hydrocephalus? Those are different entities. I am not talking of those entities. That is a different entity. I am talking of Chiari and syringe. I am talking of basilar invagination, craniovertebral related issues, and syringe and Chiari, where the world is treating today by foramen magnum decompression, those entities.
Yeah.
You understand what I'm saying?
Yeah,
I'm
absolutely.
not talking at all about craniostenosis. Of course, you cannot treat craniostenosis by C1, C2 fixation. Of course, you cannot treat hydrocephalus by C1, C2 fixation. Of course, you cannot treat. I have reported several tumors with Chiari where tumors removed, Chiari goes. I have reported several cases of hydrocephalus. You treat hydrocephalus, syringe goes. I'm not talking about those problems. You understand what I'm saying?
Yeah.
I have shown in my presentation today more than 120 cases of Chiari and syringe. I have got an experience of more than 600 cases of Chiari and syringe treated by C1, C2 fixation. I don't want to enter into any kind of discussion. I am saying what I am saying, and this is my philosophy on the basis of my experience, which is beyond 600 cases with all kinds of Chiari and syringe and all kinds of craniovertebral junction related issue. I am introducing this new concept, and I am showing you several hundred. I have shown you today more than 120 cases. So this is what I believe. And country or what, Shailendra, when I wrote this article in Journal of Neurosurgery, you know what the comment was? That patients in India are different and patients in America are different. This is published in Journal of Neurosurgery. You read the comments. I am saying people, whether they are from India or whether they are from England or whether they are from any kind of world, whether they are from Latin America, Chiari remains same. Chiari is a manifestation of unstable atlantoaxial joint, and atlantoaxial stabilization is the treatment, whether the patient is from England or whether the patient is from America. Other thing is, even we reported Chiari malformation in a chimpanzee. Even in a chimpanzee atlantoaxial, this has been published, treated by atlantoaxial stabilization. So it is, it is a matter to be, what I am presenting is a different thought process.
Okay. Yeah, I got it. I mean, totally understand your thinking about that. And I completely understand when there is craniocervical instability, when there's craniocervical issues, when there is a basilar invagination, I think I would definitely.
Not only basilar invagination, even when there is no bone abnormality. Chiari malformation is a manifestation of unstable atlantoaxial joint. Even when there is no basilar invagination, even when there is no assimilation of atlas, so they are the children of one father. So that is why I say, understanding the issue of central or axial atlantoaxial instability is a complete revolution in the field. And I am now talking not on the basis of 1 or 2 or 3 cases. Now I am talking of C1, C2 fixation in more than personal experience, more than 4,000 cases. So you should imagine, you have some disadvantages when you are in such an Indian kind of situation, but you have advantages of the number of patients which nobody can ever have. So that power we use.
Just a question, because I want to know what is your algorithm of investigation these patients. If you find a patient who comes to you, what is your algorithm of investigations?
You know what, Shailendra, unfortunately, what you said, I don't want to subject it to investigation and all those things, which are very, very, this is not science. What we are doing today, nowadays, and which I'll briefly mention, I didn't mention too much, but these patients of Chiari malformation, of syringomyelia, have unstable bone. This is what I mentioned. But now what we are doing is, we are doing these pictures in dynamic imaging. And this is also, I have published on some occasion. I have shown some papers on that. Role of dynamic imaging. You do rotatory CT scan, and you see the facetal malalignment, tremendous facetal malalignment. and more than 3 millimeter facetal malalignment on rotation and on head tilting. You tilt lateral, you tilt right side, you tilt left side, you rotate left side, rotate right side. You do flexion, extension, more than 3 millimeter malalignment of facet, even by the paper of Fielding on rotatory dislocation, which he mentioned 3 millimeter. But what my parameter is, more than 3.5 millimeter malalignment on rotation or on head tilt is suggestive, and more than 5 millimeter is indicative. If 3.5 is suggestive, 5 millimeter is indicative of unstable C1, C2. So this is for all my cases now, I do head rotation CT scan.
Excellent. Thank you.
Okay, thank
There
you.
might be more questions.
Okay, Victor, next question.
Hello.
Yes.
Hello, Victor. We have another questioner, please.
Marcos was asking another question.
Yeah, Victor, anybody else? Victor?
Professor, do you think the Chiari is the same in all over the world, or each region of genetic influences has different behaviors?
No, no. I answered that question, that Chiari is a Chiari, whether it is in Brazil, whether it is in India. The only thing, now you will ask me why it happens. You see, nobody knows why it happens. But, in the incidence of craniovertebral junction problem or instability is more common in Indian subcontinent. You will ask me why. Nobody can answer, but I have attempted and I have written on this. In India, we have little bit poor delivery practice, like fetus delivery, we deliver with forceps. Forceps delivery is very common.
Yes, delivery. Yes.
Delivery. So forceps delivery is still common in India. And my understanding was that this forceps delivery can damage the craniovertebral junction more commonly in India. But craniovertebral junction is also common, frequent in China. For instance, there are several people in China reporting, I don't think China, they do forceps delivery kind of thing. Also, what, protein calorie malnutrition and all those things can have an issue. So the thing is, they are more common in Indian subcontinent, craniovertebral junction instability. And as I mentioned, Chiari is a manifestation of craniovertebral junction instability. So it is possible that the incidence is more in this subcontinent. And in Brazil, for instance, there are several cases of basilar invagination reported from Brazil. One of the very big series of, some of my good friends from Brazil have reported very big series on basilar invagination. And there are some, landmark articles from Brazil on basilar invagination. This basilar invagination is common in Brazil. And also Chiari malformation. I know my friend Hildo, very famous.
Recife, yes. Recife, yeah.
Yes, he was repeatedly telling me about, I had a lot of discussion with him. And, Marcos, I have operated in Brazil, in Rio, on cases of Chiari malformation with some beautiful results. And I may be operating again in Rio very soon. And I wish that you join me there to see. So to answer your question,
thank you.
Brazil Chiari and Indian Chiari and American Chiari and English Chiari are the same. There is no difference. And chimpanzee Chiari also the same.
We'll televise it all.
Harshad, you always have some fantastic question for me. Harshad.
Thanks, Professor Marcos. Do anyone have a question or comment for Dr. Atul Goel?
Yes, hello. I am here. I am Dr. Hamid.
Hamid, yes, Hamid.
Hello, my professor. I missed you so much.
Tell me, Hamid, how are you? And tell me your question.
Sir, I haven't a question. I have only explanation for all the world, because I was with you the previous 9 months. I see by my eyes, I see the magic. I work with you thousands of cases from every tumor and spine and everything. About 170 keys C1, C2 fixation. I see the basilar inflammation. I see C1, C2 instability. I see all the issue related to C1, C2, and I see the magic by my eyes immediately after operation. So I hope from everybody in the world to visit you in Mumbai and stay with you. When I came to Mumbai, I did my decision. It was stay with you only 3 months. I stayed 9 months, and I hope to stay too much time with you. But you know the situation. So I am very very happy to hear you today and see you. And I advise everybody to come to Mumbai and see by himself the magic, the real magic.
Thank you, Hamid. Thank you, and best wishes to you. And you must show this magic in Yemen. And
Inshallah, sir. I'll
call
do,
me,
inshallah.
call me when you are doing this magic. I will come and see, okay?
Okay, sir. Thank you.
Thank you. Professor Atul.
Bye-bye.
I have a question. We know that you have developed your own instruments for atlantoaxial instability, screws, plates. What is the cost of this kind of surgery, especially the cost of these instruments for this procedure, compared with other?
These are very, very reasonable cost. These are not expensive instruments at all. And you know, Victor, I have worked all my life with poor people, all my life in completely those who could not afford any money. I have worked in that kind of situation. And these instruments, of course, now we have developed them. Now they are titanium instruments. They are a little expensive, but not very expensive. Just even if there is a patient who wants to get treated in a private hospital, I will say the cost of the instrument, the implants, will not be more than, I think, not more than $400 or $500, if at all. And that also I'm giving you, I don't know the conversion, but not more than $400 or $500, Victor.
That's amazing. That's amazing, Professor Atul. Thank you so much.
Also, Victor, I can do it in $10. I'm talking of private hospital, but in my hospital, I can do this in $10. So it can be that cheap. You know, these are, you know, of course, when you get companies involved and all those things, it can be expensive, but not more than $400 or $500 in private hospital with companies with titanium, medical grade titanium implants.
Thanks, Professor Atul. There is a question for Nicholas Sirmos. Go ahead, Professor.
Hello, Nick.
Good evening from Thessaloniki, Greece. It is a great pleasure to see you all. And Professor Victor Hugo Perez, that we met in some congresses, and special guests such as my dearest friend Atul Goel. The lecture was magnificent, as always, and it is a great lesson for us, the young neurosurgeons across the world. I wanted to ask Professor Goel, because in Europe, we discuss this argument also other times, because in Europe we have the older people, the population is getting older with the passing of the years. What is the impact of the generation of the cervical spine in the approaches? How we can manage the elderly people, because sometimes the degeneration is very progressive, and we have to be very careful. I want only a small comment of your great experience about that. Dear John Bennett, the webinar is fantastic. Compliments to Professor Hugo Perez, and also compliments to Professor Goel. Thank you very much.
Thank you, Nick.
Thank you. I will be giving my next presentation on degenerative spine, next presentation. And I want you to join me in that program on degenerative spine. And I will try to answer the question of what happens as the spine becomes older, and what happens as the spine becomes degenerate, and what are the natural ways that protect the spine from getting affected, neurological affection, and all those things. I will give my next presentation, Nicholas. Okay, and I want you to join me.
Okay, thank you very much, dear Atul. Hope to see you again in real life.
Thank you.
Okay, any closing questions from anybody?
Yes, please.
Go ahead. Go ahead,
Hello,
Mohammed.
Dr. Goel.
Hello,
Dr.
Mohammed.
Goel,
Yes,
how are you,
yes,
sir?
I'm very good. Tell me some nice thing, Mohammed.
I'm want to asking right now about some tips and tricks in the technique. I want you to discuss a special lecture about tricks on the craniocervical technique regarding highly arched vertebral artery, highly arched vertebral artery, and the simulation of atlas. How can we deal with these problems or these situations? How can we put the screw safely? I saw more than 200 cases with you when I was in Mumbai, and I saw that you put all the screws without using radiographs. You put it just using the microscope and freehand. But this is difficult to young neurosurgeons. You have much experience, more than anybody in the world in C1, C2 technique. So I want you please to give us a concise lecture about tricks on special situations of C1, C2 screws.
Now you tell me about your experience of Chiari when you were here. What was your experience with Chiari and C1, C2 screws? Tell me.
Was very nice, and I saw like Dr. Hamid said, the magic immediately post-operative. I saw the comfort of the patient, the smile of their families on their faces. They were very happy, and I saw a lot of cases with you, more than 200 cases. Out of them, about 35 cases of Chiari malformation. It was very nice, and I saw marvelous improvement. But this is not allowed in all area of the world, because the conventional treatment is accepted in my country. But I'm fighting to do the technique in Chiari malformation here in Cairo.
So my best wishes to you, my dear Mohammed, and I'm sure
Thank you,
you
sir.
will. You are in a wonderful Cairo hospital. I have visited you, and you are a special person. Like Hamid is my special, very special and dear. Mohammed, you just continue your hard work. You continue understanding the subject. Craniovertebral junction surgery is not easy, as you know. Craniovertebral junction surgery can be dangerous. It can be bloody. You can have a big complication. But if you do it properly, you do it nicely, you give a new life to these patients. So you study this subject in anatomy, go to the anatomy lab, see more and more cases, develop more and more experience. In the early part of your experience, you can use navigation, you can use various kinds of intraoperative adjuncts. As you know, I don't use them, but I think they are good, and you should use navigation in the initial part, particularly when there is high riding vertebral artery, particularly when you are not very familiar with the location of the vertebral artery. So you can use it. So it is difficult, and you have other options like use the inferior facet of C2. You can use spinous process screws. You can use laminar screws. You can use intra-articular spacers as standalone fixation. So there are various other options when the vertebral artery is high. And I had actually talked about this in my last lecture. when I gave to Latin American. This is my second lecture. In the first lecture, I think John must have recorded it. You can see in that as to how I do in cases of complex vertebral artery situations, Mohammed. Okay?
Yes,
Yeah,
sir. Thank you.
okay, one last comment before we leave, and this is why we do this, Atul, from Elias in Africa. We request the king to do a series in Africa to shine a light on the cranial-cervical junction.
Yes,
Isn't
yes.
that wonderful? A continent requesting you, a continent. That's fantastic. So
Thank you, John.
I thank everyone for participating. Abby, Victor.
John, before we leave, I want Harshad. Is he there on the screen or no? Harshad Parekh?
Yes, I'm there very much. I was listening to you continuously, and I don't think there is any doubt about what you say. And this craniovertebral junction anomalies, and for treating this Arnold Chiari, we all were doing the same foramen magnum decompression and syringostomy and syringopleural shunt. But after you hammered in our minds, no, it is an instability which causes the problem, and we have started doing, and there is no second thought about it. It does work, and the syringe disappears. There is no doubt about it. So this is the one concept which you have evolved over these years, and number of patients I have seen with my own eyes of yours. There is no second thought. So I'm convinced the C1C2 instability has to be considered when you see such patients.
Thank you, Harshad. And thank you, John.
I have done decompression in past, it didn't work.
Okay.
Wonderful,
Thank you,
wonderful.
John. Thank you, Harshad. Thank you, my dear Harshad.
Okay.
Thank you, John.
Okay, very good. As I say at the end of every lecture, the king has spoken. That's the final word. Okay, we'll see you in 2 weeks.
Thank you. Bye-bye. Bye-bye. Bye-bye, John.